One of the exciting things about antibiotics and antibiotic pool incentives is that many governments are now really taking this seriously. And what's not on the slide is that in November of 2020, the European Commission came out with a pharmaceutical strategy for Europe that includes an antibiotic pool incentive pilot by 2021. So they've got a year to get this done. You and I wrote a letter in, a comment in as part of that process back in September, I think. And, I have to say that almost everything I could possibly have wanted to see was there in the European strategy. So that's not even listed here. Things move fast. But in England, we talked about the steady values, and they've actually now made the selection for the two antibiotics, although they have to go through a procurement process and a negotiation process to figure out the exact amount of money for each one. It's a subscription, meaning that if England needs 1 unit of the drug or needs 10,000 units, it's the same price. People calling this a Netflix model, whether you watch nothing at all or binge 24/7, like some of our children might during this pandemic. It's the same price, and so that takes the pressure off any need to overmarket. It also importantly gives the company assurance on revenue, even if they didn't exactly time the FDA approval of their drug to the pandemic, to the epidemiology. Sweden has an interesting model. Sweden has not very many of the antibiotics that have been approved in the past 15 years have made it onto the Swedish market until they become generic. Sweden has picked 4 antibiotics to support. It's a relatively small amount of money. It's not an R&D incentive, but it will support market entry into Sweden so that the drug is commercially available in Sweden and a doctor can get it if they need it. Another interesting thing about the Swedish model is that the way it's designed, you could scale it up and make it an R&D incentive. And so there are other countries within Europe, and maybe the European Commission as well, who's interested in seeing whether that's something they can build off of, or if the English health technology assessment model is a different way to try to approach how to implement this. And then finally, you have the United States, the PASTEUR Act and the DISARM Act. The PASTEUR Act takes ideas that, not really directly from an article that you and I wrote, but certainly the idea of let's lay out characteristics of a drug that would be worthy of certain values. And as they are able to tick those boxes, we can talk about this in a moment, they receive an assurance of how much money they would receive once the FDA has approved their drug. They would have a good sense of that much earlier in the drug development process. Because the quality of the drugs will vary and whether they tick the right boxes will vary, the PASTEUR Act lays out $750 million to up to $3 billion per drug. You talked about England's fair share being $130 million or 100 million pounds over 10 years. Here, PASTEUR, the US fair share is articulated at the $750 to $3 billion, also over a decade. This PASTEUR covers all US federal sales, so Medicare, Medicaid, the Veterans Administration, CHAMPUS, DOD, Indian Health Service, the lot. Doesn't cover private health insurance. So the companies still have an ability to make additional revenues off the private side. So it would give a guarantee of revenue. Again, whether the federal government needed 1 dose or 100,000 doses, the price would be the same each year.